In the world of medicine, where every decision can change lives, your peace of mind is crucial. This is where Pattern steps in. Imagine insurance made simple, fast, and personalized, just for you. With Pattern, you're not just getting disability and life insurance, you're insuring your future and protecting your greatest asset, your income. In the past 10 years, Pattern has transformed the way over 20,000 doctors secure their financial well-being. Discover the simplicity of securing your future at patternlife.com or click the link in the description. What's the best way to call a consult? What's the best way to deliver bad news? What do they both have in common? Stay tuned, find out. Hey, this is Brad Block, host of The Physician's Guide to Doctoring. This is a personal and professional development podcast for physicians where we have experts on the show that try to teach us everything we should have been learning while we were memorizing Krebs cycle. Welcome back to the podcast. On today's episode, we have a super special guest. We have Dr. Lillian Liang Emlet, who wears many hats. She is the Associate Program Director of the Internal Medicine Critical Care Medicine Fellowship at Pitt. She is a Vital Talk trained faculty, and I've been trying to get someone from Vital Talk on my show for a while because they deal specifically with doctor-patient communication, which is what we love to talk about at this show. And she teaches communication skills for healthcare professionals in intensive care and emergency medicine. And on top of all that, she's a certified professional energy leadership coach. And when I heard she's an energy leadership coach, I was like, is this like amulets and crystals? No. Definitely not. Otherwise, right, we wouldn't be talking about this stuff. So this is going to be a great interview, and I think you are all going to love it. So Dr. Liang Emlet, thank you so much for being on the podcast.
Thank you for having me. I'm super excited to get to chat with you for this evening and talk about all the things I love to do.
So let's get to it. Let's talk about energy leadership coaching. So what is it and what makes it different from other coaching techniques?
So energy leadership coaching is basically, if you think about how you show up in the world, it's easy to just really distill it down to, well, what kind of energy do you bring to it? Is it catabolic, where you're negative, you're breaking things down, you're destructive, you're angry, you're blaming, you're a victim? Or are you anabolic, where you're like positive, you can see the opportunities, and even in the face of adversity, you can make it work. And it's very holistic in the way the approach to our coaching is from the Institute for Professional Excellence in Coaching. It was first described and studied there, and it really didn't have a much more cognitive feel. People are often familiar with the thoughts lead to your feelings and then lead to your action. It's sort of a very linear path to reality. Yeah. And we all know if we could think ourselves out of problems, we would be we're all very intelligent physicians. We would have done that, but that's not the reality. We also have a lot of energy, emotions, and a lot of foundations to what we bring to our coaching. And we feel that everyone is a leader of their own life. And so when we coach people very holistically. Some people come to us more for like the executive level energy leadership coaching, and then we add on different principles related to leading your team. And then some people actually come to us, in times of transition or in times of wanting to do a shift or figure out what the next big thing in their life is. And those transition types of well-being do require a more holistic evaluation of what's not working, the catabolic things, versus what is working, and how do we move towards the things that are working. We have 7 levels. We can go deep into the 7 levels, but that we can save for a different episode.
If someone is debating between, they're already sold on they're a candidate for coaching, right? They're maybe feeling stuck in their career, or there are things that they want to improve. Is there a specific type of person or point of their career where you feel like this would be the right type of coaching for them?
I would say probably that you actually have to really want to have a very specific goal and need to really invest that time. And so I think most people benefit from at least 6 months because we're actually into big shifts. We're not into little shifts. I mean, I know a lot of people do a lot of different group programs regarding well-being or maybe recovery from burnout. And those are very targeted to solve a specific pain or problem. We're actually much more holistic. People come to us often with this nebulous. So for example, a couple of our clients are, I just got promoted to division chief. Oh my goodness. It's a lot. I need to juggle everything that I'm doing, plus all of my teams and projects and research and my family. So they come for that holistic kind of organization of everything in life. And that tends to be like a 6 to 9 month sort of engagement because it's really about making permanent, great habits so that you succeed and win in that career in your life. Other people come to us because they're feeling stuck. They know they're at that 10-year plateau And they basically know, okay, I don't know if I really want to go into management. I really don't love administration. Do I still like my research that I'm doing? What if I want to switch? All those big what ifs. And it's not necessarily a mentor can help you, right? So we often know that therapy is looking backwards, healing the traumas from the past. Coaching is only looking forward. I would say more into the unknown, where not a mentor can literally give you the exact pathway, but what if you want to do a little bit of everything? I mean, similar to you, we both are now in this interesting space of the podcast land. We jumped into some place that we weren't totally sure of. And often it's the coaches that help us get there because there are so many other pieces that not one particular individual can be the only person to guide you.
I do have to push back a little on something you said about therapy and therapy being something that looks backward. As someone that's currently in therapy, has done therapy in the past, I was really hoping that the therapist would absolve me of responsibility and say, listen, this is all the fault of your upbringing. But no, they were like, listen, once you've recognized like what the problem thinking that you have is, you have to take responsibility for it and you have to do something about it. So I wouldn't be as dogmatic as, well, coaching is looking forward and therapy is looking backward. I think they can both be looking backward. I think, they each have their role. And having interviewed a number of coaches, I'm still trying to figure out. I think there's significant overlap between those two modalities, therapy and coaching, and they both have their role. And you can certainly do both at the same time.
And many clients do.
It sounds like a couple of the examples that you gave were for academics. What if there's someone in private practice? Is that a scenario that you see in private practice where this leadership coaching would be the right place?
Yeah, absolutely. It's a hard world that we live in healthcare, and the teams and the dynamics that we often have to try to navigate. And as the higher we ascend in that corporate structure in healthcare, in private practice, in leadership of our healthcare systems, we find fewer and fewer friends and sometimes less and less guidance in terms of what to do with these very strange, catastrophic supply chain, budgetary issues, and personnel problems. And it's really hard to have someone that you can trust that actually has been there, because the only other person you can trust really is another CMO or another executive director of a competing healthcare system. And you can't do that. So most people, once they hit in most organizations, if you're going to be part of that leadership of that particular healthcare organization, you will get assigned an executive coach. The question will be whether they have internal versus external. And sometimes it's a mix of both. There are pros and cons for internal and external in terms of the engagement and the amount of support you get, 30 minutes versus longer periods of time versus other external validated instruments to help you in your own particular journey. And also, I think for some people, they want something that's a little bit more holistic. I mean, for us as external coaches, we actually provide a much bigger whole life aspect view compared to some executive coaches internally really are like laser focused on ROI internally. So I think it varies. For those in private practice and doing sort of startups and companies on their own, it's really also adding on sort of that business layer. So then it's really also having someone who actually is comfortable with speaking some business metrics, because that's often our stressor, right? In terms of talking about different ways that we can actually show up and make the service of our business and our new endeavors actually fit into our who we are, our why, and our values, and not feeling like you're just doing something just to do something because that's what your particular team is suggesting. So I think there are different situations where people do seek coaches, especially in the business and private practice setting.
So I definitely want to talk now about Vital Talk, because this is, a core thing that we have at the podcast where we try to improve that doctor-patient communication. So you're in critical care, right? And so there is frequently, unfortunately, bad news. Was there something specific that happened? What drove you to get trained at Vital Talk?
So for me, I have to admit, when I was in fellowship, as I became an attending, there was this whole curriculum on palliative care that was sort of piecemeal back then at the time, 15, 18 years ago at this point. I was one of the first people to actually be part of the sort of the creation of Vital Talk and the incorporation as they went from Pally Talk and Onco Talk and Jerry Talk and Onco Talk Teach, where they actually became a nonprofit. They spread the education to create facilitators in the method of their coaching style communication small group with SPs, be able to teach those things. And so through that experience, my mentor, obviously being Bob Arnold, one of the founders of Vital Talk, is a palliative care physician. All of the palliative care physicians and communication specialists at Vital Talk have a deep love and commitment to making sure that we train the faculty to be able to teach in a consistent way so that we actually focus on the empathic skills, which are really hard, both the nonverbal and the verbal, to be able to teach the next generation for how we communicate. Now, obviously, it's much larger as the nonprofit is spread into multiple specialties. There are surgeons and OBGYNs getting trained. There are social workers, PAs, nurses, people of all different disciplines coming to Vital Talk for that communication training in general. So that's actually how I fell into it, was in that space of being brand new attending and finding a need to create that sort of locally within our own department for our critical care fellows and being mentored by one of the great professors in palliative care.
So when you do teach it within your own program, maybe give us like a highlight reel. Like if we wanted to include one or two of the tenets of what's taught at Vital Talk into our own methods for discussing bad news, adverse outcomes, however you want to put it, what would you want our listeners to know?
I would say probably the most important thing is you think about, we're often as physicians in a cognitive sort of frame of reference and frame of mind, and our families and everyone else around us is probably living in an emotional state of mind. Everything that we're doing and saying to them is bathed in the emotion of stress, anxiety, and fear. And so the more that you can actually nurse and get them through those emotions, support the emotions, will go quite a ways in making sure that your cognitive information goes through. So our frameworks are actually quite easy, and you can find them at vitaltalk.org on the website. We actually have handout sheets and lots of free teaching videos and all different types of courses that you can use actually even as you teach with other junior learners. But really, we talk about like a forehand and a backhand. When you're playing in that conversation, you're going to probably actually say a fact or two in a very simple, non-jargony sort of way. And then you're going to pause, use effective silence, and then think about what the emotional state of the person who just heard it. If anything, we're often doing forehand, backhand at all times, where we're stating maybe a cognitive, simple medical fact, followed by a emotional statement, meaning this is really hard. I'm wondering what you're thinking right now, and I can only imagine what questions you might have for me.
Well, that's great advice. How do you begin those interactions? Like when you know you're going to be approaching someone with, and do you call it bad news there?
We've begun to change the name to serious news because I think when we predetermine that it's bad, we're actually imputing judgment about what we're about to say. So we actually just talk about that. This is serious news, and it's serious, and we're going to get through it together. Something with gravity. We do check in to sort of see where their state of mind is, and we ask whether or not, we ask a lot of permission in terms of, is this a good time? Do you want support with you? Do you want big picture or do you want all the details? And then, is right now an okay time to talk about what I'm going to discuss? And then
so you've already kind of set the stage. You basically, by asking the questions, you've primed them and you've given them a warning that what you're about to talk about is serious.
And it gives back some control, right? In terms of being able to sit, prepare, and realize, well, actually, I know myself. I really probably should have my mom on speakerphone. Great, excellent. Then let's get her on speakerphone. It gives a lot of opportunity where we don't just open mouth and insert foot. A lot of times that's what we do by accident, especially in my emergency medicine roots. We often did that. We just rush in and say something, and then you realize, oops, I probably should have slowed down that conversation, which literally just took 3 questions.
Well, I would imagine there's also a different level of rapport in the unit in the emergency department. In the emergency department, you just met this person a little while ago, whereas in critical care, if the patient's been there for a while, you've developed a relationship with the family.
Usually, if you're able to hopefully catch them, right? Because a lot of times we don't ever always see the family at the right time, depending on whether the policies of different units have different structures for family-centered care. But yes, we do hope that we develop some kind of relationship. And I also would argue that, especially because I teach so many emergency physicians, is that you actually can get lots of great rapport relatively quickly, especially when, as you probably have already covered in your podcasting, just sitting down, getting to eye level, taking a breath, and just taking a second or two just to set up that conversation actually sets the tone so that we can actually all be in the space to be able to both deliver it and also hear the news.
Leading a medical practice is challenging. There can be reimbursement changes, referral slowdowns, staff turnover, or drama. There are obstacles in the way of achieving your goals, or maybe it feels like you've hit a plateau. Who can you turn to for help with the business of managing a medical practice? The Physician Growth Accelerator, a private practice partner that helps you uncover and overcome constraints in your practice. They will check your business vitals, identify the root cause of what's restricting your growth, prescribe what to do about it, and help you achieve it, just like we do with our patients. Imagine a practice, imagine your practice, where stress is reduced, profits increase in both patients and staff, and you are happier. They've been making that vision a reality for over a decade. Isn't it time your practice thrived? Discover how at physiciangrowthaccelerator.com. Before we move on to critical care, because I want to talk to you about, what you would like everyone to know about critical care, do you have one last nugget, one last piece of advice for serious news?
Yeah, and so with serious news, we often talk about the fact that the headline or the actual news itself has to be really distilled down into what the sort of medical fact is and also what it means for the patient. So, for example, I'm sorry that we have found a mass on your MRI, and unfortunately, we're really worried that this is cancer. The headline is really hard to distill down for many physicians because of the complexity of everything we know about that particular field. And then when you just say a tiny hint nugget of just a headline, like when you're scrolling through your phone looking at the news headlines, that's what you're aiming for. Just a brief medical fact with what it means. Then you pause, and then we let it sink in, and then we let those emotions rise up in our families so that we can actually address it, name it, tame it, walk alongside it, and not be afraid of all the emotions. If someone doesn't show me any emotion in a conversation, I'm a little worried I didn't give a very good headline. I didn't actually say any news.
What if you get the sense that they're just so shell-shocked? It's not that they're not listening. It's just that they're probably just hearing ringing in their ears right now after you just delivered that piece of information, right? What do you do in that situation?
Yeah, man, I really say I can't imagine what's running through your mind right now. Maybe nothing's running through your mind. Would you be willing to share with me what worries you have? Tell me more about what you're feeling. Where are you feeling it right now? And we also normalize the fact that they're going to have feelings. I think sometimes it's hard to name them. It's hard to express them. I mean, even as adults, we often don't know what the actual words are. And so sometimes even just pointing to a body part or where they might feel it gives them a chance to talk about sort of how it feels rather than maybe they don't know the word, especially when in cultural situations. It's really hard to translate, especially to when someone's from a different cultural background and you're using a translator too in these situations. Something just anchoring it down to where the feeling is helps them begin to talk about something really simple.
Oh, that's a great idea. All right, well, let's talk a little about critical care. So, what we try to have on the show every so often is we have a specialist that will tell the listeners everything that they wish had been taught in medical school. Maybe it is now, maybe not. So let's say you had a bunch of your referring physicians sitting in a classroom in front of you, right? And you had their attention for a couple of minutes, right? Your hospitalists, your emergency medicine doctors, right? The ones that are calling critical care consults. What would you like them to know?
I'd probably to say the art of the consultation really is to lead with the punchline first, meaning that, hi, thanks for calling me back. I'm calling because I have a person who is on BiPAP. So they basically, then they have respiratory failure of some sort. And then they go into the story. Or thanks for returning my page. I have a person here who has hypotension. I was wondering if I could run the case by you to see whether we should move it to step down or not. It's leading with the problem.
I look at so many consults that are written by, obviously, by doctors. And it'll be like, this is an 83-year-old woman with a past medical history of, and then it goes through all of their medical problems as if there wasn't a past medical history section in the chart, right? Who was here because of decompensated congestive heart failure and, respiratory distress. That's what should be exactly what you're saying. So they don't have to go parsing through everything to figure out why the heck is this person even in the hospital? When I'm getting called for a consult, question I'm always going to ask them is, okay, why is this person in the hospital right now? I recognize you're calling me because they're having a nosebleed or it's for a trach consult or whatever it is, but what's the one-liner? So that's what you're asking for. What's that one-liner? Why are you calling me?
One-liner, and then I'm going to tell you the rest of the story from beginning to end. But first that. Just so that we can sort of gauge what the situation is. Okay, well then that's a reasonable consult. I'm intrigued. I'm listening, right? And then they can go beginning to end in terms of actions. And I think that's the other thing too. What you just described to me is not an action-oriented presentation. It's a reading from the chart, sort of history and physical kind of structure. And those things will come out as relevant, even with complicated situations. It's better to think about the action, because then you could always work your way backwards. Like, I'm calling you for hypotension. This is a person who just left the unit in the last 3 days. These are the main things that happened. And these are the last 2 days. These are the main worries we had. And then, so we have some worries about this. We've done this. Would it be helpful if I went back all the way and tell you the rest of it? No, I think I'm good. I can probably look that stuff up, right? So you can sort of decide together, do you really need me to read everything verbatim versus what the key, just relevant sort of last 12 hours action items, that, things that you're worried about, things that were not quite right.
I think what you're doing is you're making a recommendation for how to call a consult to anybody.
Probably
Really.
so.
This is the reason I'm calling you, and here's a little more information about the patient. Right? Rather than leaving me in suspense about what the reason is that you're calling me until the end. It's like I'm with bated breath about why I'm being involved in this patient's care.
Right.
And maybe you're leading with a hook.
Right.
You're not leading with why you're in fact calling me. So I think this advice could apply to anyone who's calling a consultant.
Right. I mean, we call from the ICU all the time. We call ENT, we call renal, we call ID, sorry.
Everybody.
Yeah, we call everybody from the ICU as well. So I think, and especially when we call someone at midnight, we feel really bad because we're up. We're always up. We don't mind. But I think we always are sensitive to the fact that we're trying to call before midnight with a warning sign of, I'm warning you now that we've given 3 boluses already just to keep you in the loop as the surgical team, right? Because we often call our surgeons at home to keep them in the loop of what might happen. Even for hyperkalemia, we often try to ward off having to call at 2 a.m. because no one thinks better at 2 a.m. Everybody thinks a little bit better before midnight.
Sometimes not me, though, because if I've just fallen asleep, I've got some sleep inertia behind me, and I'm projecting brain cells further away from the surface.
That's true.
What if you had a different audience in front of you, right? Let's say it was a graduating residency and fellow class full of doctors of all sorts of specialties. They're about to be attendings, working on their own, not necessarily your referring doctors, but all throughout the hospital, all throughout the community. What are some things you'd like them to know about critical care?
I think there's that spiny sense that it's really hard to articulate, and I think they actually have it, and I think they're just not sure. And I think it's really great when they do call, whenever they try to piece the puzzle together and they basically apologize ahead of time saying, I'm really sorry to have called because I'm not 100% sure. So they sort of understand where their limits are and they piece together enough of it. I'm like, oh yeah, well, that totally makes sense. This is clearly this, and therefore you should do this, and we'd be happy to take them. Or thanks for this consult. I think being really upfront of being unsure, or at least thinking it through 90% of the way, helps them in their development. And also feel more confident that I actually do know what I'm talking about. And that is actually the actualization of that spiny sense of something's not right. And at the same time, also to have a thick enough skin that we're sorry that we're a little grumpy when you call us, especially with the warning. If we're dealing with somebody else's problems, or we're actually just, being divided amongst different floors and different catastrophes, we have to sort of triage, just like in the emergency department, we have to triage which problem inside this hospital is actually the one that's going to be the most where I actually physically need to be as compared to just do a telephone consult. And we can be a little snippy sometimes when we're just trying to divide our attention in that way. And so I think a little forgiveness, and also to recognize that sometimes being upfront about what kind of consult or conversation this is going to be, or if we can have it in a couple more minutes, can wait, is also really great. So be oh, it sounds like you're really busy. I'm actually okay. I just wanted to run something through. Great. Okay, give me another 30 minutes. I need to finish dealing with something else. I can come up. So I think also being again, leading with the problem first before just talking for 30 minutes and then I'm getting more annoyed because I've got other things going on. And also to recognize we can do more than one thing at a time that are pretty high stakes. And so we apologize. We sort of interrupt ourselves, and we actually just will say one thing and then go back to doing another thing, and say one thing and go back to another thing.
But how do we know if you're busy taking care of another problem? Is it because there's always beeping in the background? It doesn't matter what time of day it is. It's not like the sounds can give us some indication.
No, yeah. There's no way to know. And so I think the reality is just understand that we're always a little distracted. It's sort of if you just thought about it, can you imagine just calling the emergency department in the same way? It's not that different. for some units. Other units, it's not bad. The coverage is actually pretty good. Things get tucked in. We have a lot of either nurse practitioners, fellows, residents, people manning things that you can take a step back and take a phone call, but it's hard. We always want to be really quick to respond to the page or the telephone, like depending what system you have. We want to be there quickly, but I think the downside of responding so quickly to every single page is that then we have to divide and conquer, I think, cognitively unto ourselves. And we sometimes have a little bit less social graces on the telephone because of that. It's not as relaxed as it is like right now.
Is there anything that you wish you knew about critical care, or when you signed up, right? When you applied to fellowship, either that you discovered during fellowship or as an attending, that you would want potential trainees to know?
I think it's a marathon. And yet at the same time, the most important thing probably is to actually take care of yourself and see that there are micro moments for self-care, even amidst the busy. Physiology will continue to be physiology. Everything will continue to beat on. And so you can think you need to be somewhere or doing something or checking something. And the reality is, even if it's running through a rapid response or a code, you can take 1 second to take a breath, to center yourself so that you're as precise as you need to be in that moment. I think a lot of times we let the external environment buffet us. There is a lot of noise, like you said. There's a lot of beeping noise, signal noise, distraction, and you could let it blow you around. And I would say probably just to recenter and to know that way you can actually be present for so many different things and different types of people at different parts of the care team and not lose yourself and not sort of get swept away in either the emotions or the crises or the busyness or the incessant annoyances that people complain about, right, in the healthcare system. I would probably say that.
So you have a podcast as well, right? So why don't you tell us about your podcast and where people can find it?
Sure. So we are at Transforming Healthcare Coaching Podcast. And our goal with our podcast, with our team of 5 other energy leadership coaches, is to really bring awareness for what coaching can bring to the healthcare industry. We really feel that we can transform healthcare one person at a time by leveling up their work and life. We actually think that we can actually prevent burnout. We actually think that we actually became your guide on the side sooner for all different types of problem, whether they be personal or they may be work or they're a little bit of both, that we actually can find someone who's the right fit for you. And so we talk about all kinds of different topics that are related, that are coaching advice for people who are in the healthcare industry. So we actually help serve doctors, nurses, physician assistants, NPs, social workers, PharmDs, whoever, RTs, PTOT.
Well, fantastic. Dr. Lillian Liang Emlet, as you said, potentially your guide on the side. I like that. Thank you so much for your time and all you do for your patients and the healthcare profession in general.
Awesome. Thank you so much for having me. And I can't wait to have you on our podcast so that we can bring your community over to ours and share all the cool things you're doing over here and really helping physicians level up in their personal and professional lives through your podcast.
Doctors dedicate our lives to caring for others. It's time someone took care of us. Visit patternlife.com to simplify your path to peace of mind. Patternlife.com, simplifying your insurance journey. Thanks for listening. I have a favor to ask. You listened to the episode until the end, which means you either fell asleep or you really liked the episode. So please share it or like it or comment on a social media post or write us a 5-star review. Something. It would really help me out. And maybe what you learned from this episode can help someone else too. The views expressed in this episode are those of the interviewer and interviewee and don't represent the views of their employer or even their significant other. Even though the magic of podcasting make it sound like I'm talking directly to you. This is not a doctor-patient relationship, and this is not medical advice or financial advice or really any advice. Thanks again for listening to The Physician's Guide to Doctoring.